Broadcasting from UF North. So it's a little different for a Grand Rounds presentation. But I'm speaking today about variant histology and bladder cancer. Good morning, everyone. Everyone has seen that now. I've moved to my first page. Everyone can see that, correct?
Yes, Mark, we see it. Thank you.
Okay, good. Thank you. So today I'm discussing variant histology and urothelial cancer. Urothelial carcinoma has the unique ability for divergent differentiation, and it's able to produce a variety of histologic variants of urothelial cell origin. These divergent morphologies coexist with a typical pure urothelial cancer. So we're going to be discussing today the pure variants, which there are two I'm going to be discussing, which are pure, but then the divergent morphologies or the mixed variants coexist with the typical pure urothelial cancer. That's important to have that distinction between the two. The pure variants we're talking about today are squamous cell carcinoma, adenocarcinoma, and then there is a variety of mixed variants that are with the pure urothelial cancer, and that's the micropapillary, the plastocytoid, nested variants, the squamous and glandular differentiation, which we see frequently, neuroendocrine, and the sarcomatoid. That's the small list. This is the larger list that you'll see. This is from the WHO classification for urothelial tract tumors. And this is a large list, but mostly just for reference. But you see within that larger, like the infiltrating tumor, urothelial tumors, you're going to see the macropapillary, the sarcomatoid nested in that group, the pure squamous, neuroendocrines, the glandular, the urachal. So this is the entire list just to be complete, and you can use that as a reference. Variant histologies have a worse prognosis than the pure urothelial cancers. These variant histologies have the tendency of always presenting at a higher stage. They develop metastatic disease. They demand prompt recognition and definitive therapy because of their aggressive nature. It's really to understand if you have a muscle invasive bladder cancer with a variant histology, the standard of care is immediate radical cystectomy with or without neoadjuvant chemotherapy. However, the unknown is, what do we do with the non-muscle invasive bladder cancer with variant histology? And the optimal management of this group is unclear because they're non-muscle invasive. The AUA and SUO guidelines classified non-muscle invasive bladder cancer with variant histology as high risk. And there's a recommendation for immediate radical cystectomy or repeat TURBT. This management is controversial, and so that's what we're going to discuss a majority of the time today regarding these different variants. Now, this is an algorithm that everyone should have on their refrigerator. I have it on mine, but my wife keeps tearing it down. But you can see here that it starts with, this is the algorithm for non-muscle invasive bladder cancer by the AUA and SUO. And it starts with a TURBT. But if you look down here at the higher risk, you see that all the other lines are solid, but these are all dotted. So that's the reason why there's this controversy here for the T1, the ones that with or without the variants. The high risk, you go to cystectomy, but then there's in part of that, and that's what we're going to discuss, the need for a repeat TURBT plus or minus chemotherapy. And so we'll see later that if you do a repeat TURBT and there's still that variant, you still go to cystectomy. It's high risk, very high risk. But if you don't, you can go to BCG and continue bladder preservation. So today we're going to review the pure and mixed variant histologies. We're going to explore their unique characteristics. I'm going to highlight how their genetic alterations influence their aggressive behavior. And you're going to see the importance of now in the modern way of managing bladder cancer, that it's not only the histology that is identified, but also we're going to be identifying genetic alterations. This is what I promised you, that we're going to talk about genetic alterations because it's absolutely necessary to talk about genetic alterations. We have to know this. So, and then finally, we're going to develop a management algorithm for non-muscle invasive bladder cancer with variant histology, and which has been published. So, what about this group, this aggressive group of urothelial cancer? Has been an increased incidence of variant histology in radical cystectomy specimens. And it's not because it's getting growing, it's because there's an increased pathologic recognition and reporting of these variants. Pathologists are learning more about it, and there really is a thought that the academic pathologists are ahead of the community pathologists. Linder in 2013 re-reviewed 1,200 radical cystectomy specimens diagnosed with urothelial cancer in the group of from 1980 to 2005. And this 33% of them were reclassified as having variants. Likewise, Mosini in 2017 looked at 31 to 32% radical cystectomy specimens, and there was a variant histology component. And he actually saw that there was an increase from the 1990s to the present time, again, demonstrating there's not like a new group of these, but they were just being recognized more and being reported. Also, looking when we're performing the TURBTs, there's an increased TURBT specimens have variant histologies within non-muscle invasive bladder cancer. And the Stanford group noticed that 10% of their TUR specimens have variant histology when they saw T1 disease. Experts from the University of Michigan re-reviewed community TURBT specimens and found, in fact, 44% missed variant histologies. So the TURBT only identified variant histologies in 6.4% of patients compared to 14% in the radical cystectomy Mosini found. So there's definitely a difference in the recognition of this variant histologies when we're performing TURBTs. And also it goes back to how well we are performing TURBTs to find them. So we're going to look at the variants, pure variants first, and kind of go down this list today. Squamous cell cancer. It's interesting that this is a very rare group of cancers. 2 to 5% of all bladder cancers are diagnosed. And we know all this well, that it's associated with chronic inflammation, with schistosomiasis. But what's interesting is how it was reported differently. In the endemic reporting, there was a similar overall survival between the squamous cell and the urothelial cancers in a group of 2,700 radical cystectomy cohorts that had greater than 50% squamous cell cancer. But the survival was the same. However, in this 2012 report from Memorial Sloan Kettering, it's what we usually would find, that there was the squamous cell cancer had a worse overall survival and disease specific survival compared to the urothelial cancers, making them more aggressive. a SEER study looking at squamous cell cancer from 1988 to 2003, and 85% of these had muscle invasions. Stage for stage analysis, the squamous cell cancer had a worse survival only in the non-organ confined disease. And metastatic disease, the squamous cell cancer had worse survival than the urothelial cancers. So it's really thought that these squamous cell cancers are very aggressive, and a radical cystectomy really is the only option. Other studies show that the use of neoadjuvant chemotherapy or external beam radiation therapy had no advantage. Excuse me, water. Regarding adenocarcinomas, their primary adenocarcinomas are also very rare, 2%. There are two.
Mark,
Yes,
can I
sir.
ask you a question, Mark? What's the role of neoadjuvant chemotherapy in squamous cell?
There is none. There is not a role. I could have given you that information, but I mean, I just was brief in looking at that there is no role, and that the radical cystectomy should go right. So that in the studies that were I've reviewed, did not find a value to neoadjuvant chemotherapy or radiation therapy, and cystectomy should be immediate.
Okay, thank you.
Yeah, primary adenocarcinomas, we know there are two types, urachal and enteric. The urachal adenocarcinomas have frequent metastasis, local reoccurrence, and a poor prognosis. And I think I don't know who is all involved with me with this case recently, but she had very advanced disease throughout the peritoneum. Everything was resected. She's on chemotherapy and is doing well at this point. In a SEER analysis, the 5-year cancer-specific survival is 57%, and overall survival is 51%. And it's important to have the effective en bloc surgical resection of the bladder dome. The urachal ligament are mandatory. Some people also believe of taking the umbilicus. Yes, I just, in that way also, Dr. Blasio, this is just like bullet points of each cancer to kind of review all of them today. What's interesting about these adenocarcinomas, the urachal and enteric, they're very similar histology, biology, and genetic alterations. And that also is very interesting that we need to start looking at these genetic alterations. Both of these have objective responses with these similar systemic agents, the 5,4-uracil, leucovorin, and oxaliplatin. Next generation sequencing has identified TP53 mutations in 80%. They're also the epidermal growth factor and fibroblast growth factor amplification, 35%. And so it shows that these two adenocarcinoma have the same histology, different organs of the source from the bowel versus the bladder or the urachus, but they have genetic similarities. And it was found that when they targeted with an anti-epidermal growth factor monoclonal antibody, there was a reported response with this other form of therapy. That's the pure variants. Now we're going to go to the discussion of each of the mixed variants. And we have to always remember, again, these mixed variants are mixed with the urothelial cancer. Regarding micropapillary, MD Anderson has one of the earliest experiences of micropapillary, and they reviewed in 2007 their 100 micropapillary bladder cancer patients. They were on all stages, but the interesting part was that 44% of them had non-muscle invasive bladder cancer. And they attempted bladder sparing with intravesical BCG. in 27 of the 44. However, 18 of these patients, 67%, developed disease progression to muscle invasive disease. And actually, then 22% also developed metastatic disease. So, bladder, and you'll see that bladder preservation wasn't a good idea. So they concluded that you needed early radical cystectomy. This micropapillary variant was associated with poor prognosis. The BCG was ineffective. They also found that a neoadjuvant chemotherapy resulted in worse survival compared to the immediate radical cystectomy. So they believe that early radical cystectomy is necessary for surgical resectable disease. This information was substantiated with a SEER study of 120 patients, and they had similar stage comparisons in a non-muscle invasive micropapillary bladder cancer versus the pure urothelial cancers. And it was the micropapillary significantly worse survival outcomes. The MD Anderson group went back in 2015 and reviewed their group again, and found that they studied now this time 72 patients with T1 micropapillary bladder cancer. 40% of them had primary BCG, but in that group, 75% had reoccurrence, 45% had progression, even to node positive disease, and 35%. So again, they believe that initial radical cystectomy had improved 5-year cancer-specific survival. However, there is a controversy with this because this Memorial Sloan Kettering group found that bladder preservation was possible. In 2014, they looked at their group of 21 patients with T1 macropapillary disease and treated with intravesical BCG after restaging TURBT. 25% of them had a micropapillary involvement on the TURBT. They found that there was no difference in the 5-year cancer-specific survival between the T1 micropapillary with BCG versus the initial radical cystectomy. And their BCG group had a similar 38% reoccurrence and 10% progression as with the pure urothelial cancer. Can someone tell me why would we see this difference between the groups? Any of the residents, Umar, have any thought about why would we see that? You have the best medical centers. Why would you see a group knowing this information? Any thoughts? Silence. The difference between the two is, and looking after you review these two articles, is the re-resection with the TURBT. Let's see, the MD Anderson group, that was a historical group going back to 100. And so it's a large referral center. And so they're going to have people come in and have their bladders removed. I've been there, done that. But the other, Memorial Sloan Kettering is more contemporary, and there's been more of an influence on re-resection with the TURBT. So that's really important, and that's one of the take-home messages here, that for optimal management, this controversy is really cleared up because it's really necessary to have a well-resected bladder, and that's just a mantra that we talk about all the time, but it's really important here because these tumors are very heterogeneous, and the TURBTs have to be performed well, and so if you have how we routinely do a repeat TURBT after a T1, well, if we have micropapillary, if we have any of these mixed variants in our TURBT specimen, then we have to re-resect again too. So part of the management you'll see is that if there's a immediate radical cystectomy with or without neoadjuvant chemotherapy, if you have a large multifocal mass, or else if you have a BCG reoccurrence, but then also in those guidelines, you have a repeat TURBT guides the management also. Micropapillary bladder cancer has a unique genetic signature that explains its aggressive behavior. And this can also be used as a target for therapy. Micropapillary bladder cancer has an overexpression of ERBB2 oncogene up to 66%. And using this information and then treating with a small molecular molecule, there was improved progression-free survival in platinum refractory metastatic urothelial cancer. So this gives us an example now of that, not only to use these genetic signatures to identify them and explain their aggressive behavior, but now we can also use this information for targeting for therapy. Here's the algorithm that, if you look on the right side of this algorithm for TA, T1 urothelial cancer, that from macropapillary, now we're going to go through the placidotoid, nested, the pure adenos, the pure squamous. So if you have a multifocal large tumor with lymphoproliferative invasion, recurrent BCG, go right to cystectomy with or without chemotherapy. However, if it's a smaller amount, then repeat a deep TURBT. If it's negative or only pure urothelial, then you can consider intravesical BCG. If it's not negative, or if there's recurrent or persistent variant histology, again, go to cystectomy. So this is this part of the algorithm that we're going to cover right now. And then we're going to go through other parts of this later. Another mixed variant is a plastoid mixed variant. It's looks as like an intracellular mucin signet ring or plasma cell-like appearance. The MD Anderson series, where 85% of them were greater than had advanced muscle invasive disease, were found to be locally unresectable metastatic disease. And they found that cisplatin-based neoadjuvant chemotherapy was not beneficial. The overall survival was bleak with 17 months. These are associated with the mutations in the gene, the CDH1. If you have a mutation of this gene, there is loss of the E-canderin enhanced cellular migration. This promotes, with the loss or mutation of this gene, promotes tumor invasiveness into muscle and perivesical tissue and carcinomatosis. So this mutation explains this tumor aggressiveness. And you see that in this figure. If E-canderin mediates contact inhibition of proliferation. So when in a normal cell, if you look at this upper part, it prevents these cells from getting on each other, contact inhibition. And so when they proliferate, they all have grown a monolayer of normal cells. However, with loss of this gene or mutation of it, this is disrupted. And these cells lose their contact inhibition, so they start growing on each other and developing larger tumors. So this is the explanation for the aggressiveness of this variant. Another variant is the nested variant. These appear as bland appearing cells that mimic low-grade cancer, but are in fact invasive. there's a high suspicion when you get a diagnosis of a low-grade cells that are invading into lamina propria or muscularis. So the pathologist comes back with this. This should make you aware that this is not the benign von Buren nest or inverted papilloma that we see, but in fact is a nested variant. And these have high adverse features with advanced disease in almost 70% and metastatic disease in 20%. So because their potential aggressiveness, you must be aggressive. And so immediate radical cystectomy with or without chemotherapy. Again, that same algorithm on that right side, if not, repeat the TURBT. So again, we're on this side of this algorithm, the right side. Next, we're going to move to something that we see quite often is in the mixed variants. There's a squamous and glandular differentiation. In fact, we were looking just in clinic this last week, we're looking at a specimen that had it a couple of years ago. And so it's something that we always have to be wary of this now. And that person had a T1, was resected again, and there was no cancer in it. And he's doing well. But the urothelial cancer with squamous differentiation is most common variant in 20 to 40%. The glandular is the second most common in approximately 18% of invasive cancers. And so it coexists with other variants also, the micropapillary, so the sarcomatoid. So it's almost like in testicular cancer, you're going to get a group of these variants that could all be together. And so it's important that these are distinguished. And really the most important thing when you're looking at this group is that we have to make sure that to distinguish them from the pure variants, the pure squamous cell or the adenocarcinoma, which are typically more aggressive than the urothelial cancer with the squamous differentiation or glandular differentiation. There was a comparison in 2017 between the pure urothelial cancers and the urothelial cancers with squamous differentiation. There's higher rates of disease reoccurrence in the mixed group, and than the pure urothelial cancer, and a higher mortality. Kim in 2012 evaluated the variant histologies cohort and looked at a group that was combined with squamous and glandular differentiation. He found that there was no significant 10-year cancer-specific survival difference when compared with the pure urothelial cancers. So there's somewhat this discrepancy again between these two groups, and I still believe this is related to how well they're sampled. But in general, we are going to manage this group similar as the conventional urothelial cancers. That's the recommendations. So in general, the glandular and squamous differentiation is managed as similar to the conventional or pure urothelial cancer. So urothelial cancer with squamous differentiation like Ta-T1s. So you're going to treat them as the conventional urothelial cancer with a re-TURBT and intravesical BCG. But what's important is that the repeat TURBT is essential. But then still with this component of squamous or glandular differentiation in your specimen, you still should recognize, even though you're treating them similarly, that there's a potential that there's going to be more aggressive behavior having them present. So now we're on this algorithm, we're on the left side of the urothelial cancers with squamous differentiation. Treat them as conventional UC with a resection and intravesical BCG. Neuroendocrines. The neuroendocrine tumors can be a mixed group of small, large cell mixed with a pure urothelial cancer, and they're usually diagnosed with immunohistochemistry. But they have a very high likelihood of occult metastases, even at presentation. And because of this high incidence of distant metastases, intravesical therapy is never recommended in this group. So the standard of care for muscle invasive bladder cancer with neuroendocrine is cisplatin epitasimide plus cystectomy or radiation therapy. Now, Dr. Skinner believes that she uses it with even non-muscle invasive tumors should receive systemic therapy. So in this group, be aggressive with systemic therapy and surgery or radiation therapy. On the algorithm, again, you can see it here that the neuroendocrine small cell systemic therapy with cystectomy or radiation therapy. The last sarcomatoid variant is very rare, has less than 1% prevalence of all bladder cancers, and it's the sarcomatoid variant. And histologically, that you see this as a spindle cell morphology. This occurs, with radiation therapy or cyclophosphamide exposure. One of my TURBTs that it's coming up soon is a man who had radiation therapy, and he has a mass right in the trigon, right in the middle of the trigon after proton therapy. So I'm interested to see. We have to get this. Hopefully, this is happening next week. Seranalysis found that the sarcomatoid had 2 times higher fold risk of cancer-specific mortality versus the pure urothelial cancers. This sarcomatoid variant is chemotherapy resistant, and it's resistant because that high expression of the epithelial to mesenchymal transition associated genes were there. And this was presented really well by by Sarush a couple days ago, last week or so, in research conference. Early radical cystectomy is recommended for this highly aggressive variant. So that's the in the middle of this algorithm, the sarcomatoid or sarcoma. Move right to cystectomy. So conclusions. There's a real need for proper identification of the urothelial variant. And because today we must include that to properly risk stratify our bladder cancers. We no longer can just look at these variants as histology, but also include specific genetic mutations for proper classification. But any of these variants is indicative of more aggressive bladder cancer. And more we should be looking for genetic mutations, because they're going to help us determine prognosis, new therapies, and the response to treatment. Finally, you can see how this is growing. This is just I'm just throwing this up there to show in the literature how it's a growing group of molecular markers with different variant histologies. But it just shows how this whole field of genetics are exploding, and how we have to take part of this and learn this. I'll try to take any questions. Hello?
Hey, Mark, very nice and comprehensive talk. So I just want to, how much time do you have, Mark? What's the time now?
That's 7:50.
7:50, you got some time. So I'm just looking for audience participation here from our residents and fellows. One of the comments that one of the data points Dr. Bandy showed us was the C-cadherin loss in plasmacytoid variant. And he also told us that C-cadherin plays a role in cell adhesion, and loss of that leads to loss of cell adhesion and eventually migration, invasion, and so on. Now, could we use C-cadherin loss as a marker for a plasmacytoid variant? This is just open to any of our residents and fellows.
Sorry, can you repeat the question, Dr. Balaji?
He showed us that loss of E-cadherin plasmacytoid variant is associated with E-cadherin loss. And E-cadherin is a cell adhesive protein. So when there's a loss of that protein, if you want to show that picture, Mark, again, thank you, leads to loss of cell adhesion and therefore causes this to be more aggressive. Okay, he showed us, this is a cartoon he showed us. So could we use E-cadherin loss as a marker for plasmacytoid variant in urothelial carcinoma?
So it seems that,
I
you know, in
think a lot
some
of
studies, there is some associations between these two. I don't know how sensitive or specific it is, but apparently E-cadherin loss can be used for, or actually has been associated with plasmacytoid.
But I think loss of E-cadherins and cell adhesions is a central process for metastasis for all of the cancers.
Excellent. I mean, both are very good answers. First of all, I think Sarush's answer is accurate, that we don't know how sensitive or specific it is, and therefore I'm not sure we could use it. Followed up by Beshat's sample, which is also very accurate. It just addresses Sarush's concern that this may be a very non-specific finding. So if you look at every cancer, they tend to have a E-cadherin loss. So this is a very common finding in cancers. You know, this will, you know, some people think it's one of the earliest characteristics for a cancer to really let go of its neighbors and then start moving. Now, there is, are you guys familiar with the term called anoicus?
I am not.
Not really.
Could you repeat the term? I didn't understand.
Now, are you guys familiar with the term called anoicus? A-N-O-I-K-I-S.
I haven't heard about that.
Dr. Balaji, may I comment on that?
Yes, please.
Anoikos means an means lack of, and oikos is meaning home, is from the Greek home, and from there we derive the term oikos from economy, ecos, which is management of the home. Anyway, anoikos is, as I was reading recently in program Cell Death, is a process whereby neighboring cells kind of basically evict another cell from its home and leave it without any signals to prolong its longevity. And so it is a sort of one form of program cell death executed by neighboring cells upon a cell. And the best example I think that I read about was in the skin, where the epithelial cells are pushed toward the surface to die. And before that, they're basically deprived of any surviving signals. That was my understanding, Dr. Balaji. What do you think?
Perfect, perfect, Rebecca. That's perfect. So, guys, it's a form of programmed cell death where if you let go of your neighbor, you cannot survive. The cell needs signal from neighbors. And if for some reason it lets go of its neighbors, a normal cell cannot survive. This is, the skin is a very good example. Okay. Now, however, in cancer cells, when E-cadherin is lost and they let go of the neighbors, start migrating, they continue to survive. So they escape anoicus. Okay, so for normal cells, if loss of adhesion needs cell death by anoicus. Okay, now if a cancer cell, on the other hand, can lose adhesion, can go wander around on their own without dying, and that's one of their pro-survival characteristics, and they avoid anoicus. So cancer cells develop so many survival mechanisms that makes them last, they can go into another territory, call their place home, and so on and so forth. So E-cadherin loss is generally considered, in E-cadherin is, cadherins in general are epithelial cell markers. They are not expressed in mesenchymal cells. Okay. Now, E-cadherin, there are three types of cadherin: E-cadherin, N-cadherin, P-cadherin. But E-cadherin is the most commonly studied and the most common variety, and it at the cell adherence junction, which is the posterior lateral part of a cell membrane. Now, its loss is very, very common in most cancers, okay? Now, if you have two genetic abnormalities, and then something is very common and something is uncommon, what do we call these mutations? Now, I also understand I'm not phrasing these questions correctly, guys. This is hard to phrase a question without giving you the answer. Again, this is audience participation. At the end of this, you will know answers to all these questions, okay? So feel free to participate. And a lot of this is I'm not framing the question properly, which I can think is a continuing weakness of mine. So if you have, say, 3 or 4 mutations, and some mutation is very characteristic of the tumor, and other mutations can also occur or downstream, how do you broadly classify those mutations in cells? Any takers? Okay, so whenever we detect multiple mutations in cancer, especially, we broadly look at them as the driver mutations or passenger mutations. Okay, that's the term I'm looking for. So driver mutations act early on in the process, and then after that, a lot of other mutations happen. Now, some of these mutations are common across cancer. So we generally, now remember, common cancers can also be driver mutations, but driver mutations occur early on, and fundamentally without driver mutations, less of the other downstream mutations may or may not happen. And then once that happens, then you have a lot of other mutations, and they're called passenger mutations. So when you come across something like this, the question you need to ask yourself, is this characteristic or even pathognomonic of this type of cancer? Or is this common in other types of cancer? Is this mutation a driver mutation or a passenger mutation? And the other thing you need to ask of is, if you can do an algorithm, like something like kidney cancer, for example, you've got an algorithm. If you do not have a PBMR1 mutation, then it goes into a totally different pathway. It goes into a backward pathway. So these pathways don't coincide, they just bifurcate. And then these are what we call driver mutations. So broadly, when you guys come across all this, please ask these questions. Is this specific for this type of tumor? Is it characteristic? Is it pathognomonic? Is it driver or passenger mutation? And if we are able to draw an algorithm for this, where exactly will this mutation lie? And for this to be effective, any treatment targeting these mutations to be effective, they generally have to be driving mutations of something very characteristic of this tumor. Say, for example, if you have a p53 loss, that's across the board. Any p53 loss in any cell generally leads to cancer. It's similar to p10 loss. These are tumor suppressor genes and they play a major role in cells. And when you have loss of these proteins, they end up causing cancer. And they are hard to target as well. The tumor suppressors are generally hard to target compared to oncogenic drivers, which cause good activating mutations. But those are the questions I want our residents and fellows to think through when you hear about all these kind of things. And that's a useful algorithm in my mind that helps me to delineate the complexity. Because as you move forward, irrespective of your faith in molecular science or your judgment, whether you should read or not, people who don't keep pace with all this are going to be left behind. I can tell you that much. I can see that in my own generation, and your generation is just going to be a necessity. You cannot be a urologist who thinks of this as a foreign language. It has got to be part of your lingo. And in order for you to understand what is said out there, you need to have a broad understanding of the concept of what these things are and how to interpret this data. Okay.
Yes, if I could also emphasize that was the reason I presented this. Part of that plasmatoid mixed variant has that loss of ecandrin. So there was a genetic alterations that was found in this variant, and that's what caused contact inhibition. But I think, yes, this is more of a driver genetic alterations that we see in cancers in general. But this is just one of the ways that they presented this. Yeah, so you should really know about the loss of contact inhibition and proliferation in cancer, because that's just really a common theme of all of these cancers.
Any questions or comments from residents? Anything on how we assess genetic mutations. Well, you guys are all probably familiar with clinical use. We do NGS, they come up with a gene that we may never heard of. We quickly look up to date, see whether there is any inhibitor that we could try. And then we may be able to use that in our clinical practice. So I think that much I think we're doing well. Where we need to do is then really understand the interpretation of this, because you're going to be flooded with all this data in your practice. We found this, we found that. If you use the algorithm I just talked to you, that would really help you to clarify in your own mind how you should pursue this information you just received.
Yeah, because this is just there's a sequel to all of this that's coming up. So, but this is an interesting group of bladder cancer, these mixed variants. And I think it's really interesting to be aware of them and now to study them further in regard to their genetic alterations and how explains their biology, their aggressive biology, and then there's going to explain their prognosis. And then also it's going to give us new therapies, targeted therapies, instead of the chemotherapies no longer will be useful in it. Now we're going to have to use these genetic alterations to give us new therapies to treat them, because we're actually going to be treating not as a general cancer like with cisplatin therapies like in the past, but we're going to be using the genetic alterations to design the therapy. Any other thoughts or questions?
As of now, I mean, mostly like this genetic alterations and treating according to genetic alterations is always coming after chemotherapy or immunotherapy. So I'm just a question. I'm thinking that when would be the time that it would, the situation was reversed, where we would first think of genetic alterations and treat according to them, and then if that does not work, go to conventional chemo or immunotherapy?
Well, I think that's a great question, and but there's a couple examples in this talk, and I'm happy to share this with everyone, that it wasn't, there was no response in the cisplatin-based therapies, or else they had advanced metastatic disease. So that was tried already, so there was no other choice. But now they're going to have poor survival, or else now we can utilize these genetic alterations for therapy, and that's when you're going to use these therapies. So this is going to become our second line, third line therapy.
So if you look historically, Umar, that's a great question. Everything gets evolved over time. They start in late stages, eventually migrate to earlier stages. We have seen this with anti-androgens and prostate cancer. The challenge with targeting gene mutations in therapy is not all cells express the same mutation. So no matter what you target, you're going to have a huge escape phenomenon. And that's why I think chemotherapy still has a role, at least in the form of debulking, because it targets everything that's DNA and so on and so forth. And then you then either do a combination with chemotherapy if you have a driver or a major mutation, or kill the cells with the chemotherapy, and then you have the residual cells, and then find the main driver mutations, or at least the common mutation in those, and see whether we can target it. So it's going to ask for a combination strategy, unless there is, for example, Ewing sarcoma, you have the ETS, EWS fusion genes. And those genes can be specifically targeted because it's very, very characteristic, CML, the Philadelphia chromosome. If you have something very specific, then you can target it. I mean, most of the other cancers that we deal with, there are a variety of these things. So I think chemotherapy still probably will continue to have a first-line role in a long time. And then the residual cells might have to be specifically targeted because they are resistant to chemotherapy. Anyway, that's our thought process at this time. Things may change. I think this is so rapidly evolving. And I think from a residency and a fellowship point of view, you want to be in a residency, you want to be in a fellowship program where this is common in your lingo. Otherwise, we'll just become another technician, putting out the ectomy for us and letting others manage all the other things. That's why I think I'm just looking at it from an education perspective. These are key part of education, and I really appreciate Dr. Bandy today taking time to explain a lot of these things to us. So.
Well, I mean, a great example would be in metastatic renal cell cancer. During my residency, the survival is what, 20% survival with metastatic disease. There's no therapy for these people, and they passed away. But now all this because of understanding the genetic alterations, understanding the how the renal cell cancer gene operates, we have the tyrosine kinase inhibitors. So that's a great example. Chemotherapy is useless with renal cell cancer, but the tyrosine kinase inhibitors, the mTOR inhibitors, have now come on, and we have great control in most cases with metastatic renal cell cancer and for these patients. So that's a great example, Amar, how genetic alterations have developed, a specific therapy, monoclonal antibodies for treating these cancers. But here in bladder cancer, it just has not matured enough as renal cell cancer has.
Okay, let's not forget the Japanese scientist who discovered the catherine, Masatoshi Takeichi.
I'll write that down for the next talk. I'm sorry, I didn't give him recognition.
Any other questions from anybody?
Dr. Bendick, thank you for your presentation. I have one question regarding the, at the beginning of your presentation, you mentioned how there are studies that have talked about re-reviewing pathological slides, and they have found that and nowadays they are able to diagnose histological variants that they have greater rates of diagnosis for these variants. I would like to know, I mean, what's the reason for this? Is it because the pathologists are better trained? I mean, have they seen more cases and they know what they're looking at? Or is it because of more techniques that they're using, I don't know, immunohistochemistry techniques? And another question connecting this one, what's the role of the surgeon while he or she is doing the TURBT so the pathologist can better diagnose histological variants? Thank you.
Well, that's a great question. Yeah, and but that's kind of what I hope to have given you that information. Yes, there's a thought that the pathologists are not up to date, and this is like over a period of time. That's right, you saw over a period of time that there is an increased pathologic recognition and reporting because of that. So, and there's really thought that there's a difference between the community and academic pathologists. So that's why looking in, see, for example, the National Cancer Database, that information may not be that accurate, because the changes over time in reporting. In fact, I'm looking even maybe at our institution, how well is it reported, because there's a thought, one of the thoughts also about this, that you should have central reporting for looking for accurate identification of these mixed variants. And so, so that's really important. Actually, that's why I'm going to look at our institution now and have a good understanding. For example, because if we wanted to do some study with mixed variants, how accurate is our pathologic diagnosis? How accurate are we identifying it? And so there's really a thought of going to a central pathologist who understands it in a lot of these studies, and they're really questioning the older studies, how accurate it is. And that's the reason why I think there's a difference between the MD Anderson, the more historical study versus the more current memorial study where they did repeated the TURBT. Then your second part of your question is how well is that TURBT performed? And that's why re-resection is so critical, because it's a sampling, but how good is our sampling? Because there's differences in how well it's sampled. And that's important for muscle invasive disease that we see commonly, as we're going to do here in the next hour, TURBTs up here. But also for looking for this mixed variant, because it may be a small amount of that tissue, but it's going to be critical in identifying how to treat that bladder cancer patient, and also the prognosis for that bladder cancer patient. So it's better recognition, better resection is really required to accurately manage these people now. Did that answer your question?
Yes, it did. Thank you so much, Dr. Brandy.
Mark?
Yes, sir.
Regarding Carlos's question, I have a question about the sampling of the base of the tumor when we do either the initial resection or the re-resection. I have remembered reviewing pathology slides with pathologists, and they showed that, you know, this is cautery artifact when we use the electrosurgical unit resectoscope to obtain the tissue. And so I've been using, what I've been doing is when I get to the base of the tumor, the last part of my resection is a series of cold cup avulsion biopsies to try to get tissue that has not been burned so much. And I don't know if that's of any merit. What do you think?
Yeah, I wouldn't recommend. Cold cups are going to be inadequate. And I think you really have to use a TUR cutting with a deep resection, as deep as you dare. Cold cupping is not going to be adequate for really staging these properly.
Yeah, I'm not talking about exclusion of the resection for the cold cup. I'm talking about when you finish your electrosurgical resection, getting further samples from the base of the tumor of your resection with cold cup, so that you get some tissue that is not cooked with and burned by the electrocautery. And I don't know if that's of any merit. That's why I was asking.
I just think with a good cutting current is and as clean and deep as possible is all we can do.
Okay. Thank you.
Roberto, the other thing that has helped these days is the bipolar TURBT. We don't use monopolar anymore, or as much. So bipolar has been shown to reduce cautery artifact. But very difficulty, I think, using a cutting current will be reasonable. I think, yes, there will be cautery artifact, but if you give them a deep enough resection or a big enough resection, they should have enough sufficient specimen to look at the muscle and tumor cells in there. So. Yeah, cold cup kind of sampling though, and it's too tiny. You can get one spot. It might actually result in false negative results, which I think can be a matter of serious concern.
Yeah, I was happy when I came here to see bipolar that Dr. Costa had in his department, because I was not familiar. We did not have that in my previous practice. So I think bipolar is the way to go. Any other thoughts? If not, I appreciate everyone's